Hey guys, it's Professor Pulowski. I am re-recording the synchronous session for Professor Lombard. She did do this, and unfortunately it did not record and her voice wouldn't come through. She's having some computer issues, so I did let her know that I would do this and go through this stuff with you. So I'm going to basically go through the key points and the information here, and then I'm going to post and give you guys, I'm going to go through a bunch of the questions, and then I'll post this afterwards so that you have it. When you start and you're looking at chapter 44, so that's drugs for the pituitary, thyroid, and adrenal disorders, the things that you really need to make sure you're focusing on are the prototype drugs. So when you go through and you look at, obviously you have the review of the pathophysiology behind this stuff. As you're going through, like I said, go and kind of get a grasp for what these things are. There's the table 44.2 on page 742. Look at desmopressin there. Look at what it says there, and then look at the prototype area here. So if I flip from there and then I go to 744, what is desmopressin? So basically, it's the synthetic analog of ADH. What is ADH? It's the antidiuretic hormone. So if I give somebody desmopressin, basically I'm stimulating giving someone the anti-diabetic hormone. So when someone has acute symptoms of diabetes insipidus, so basically they're losing all the fluid, and they have insufficient ADH secretion, then they're going to give them desmopressin. You'll see this given a lot of times. You can give it intranasally as well. So there's a lot of different things. You'll see it given for. This is something I've seen given. We used to give it all the time for people who had nocturnal enuresis, like bedwetting. And then again, we can give it to patients who have diabetes insipidus. So those are big things. But if you remember, desmopressin is basically synthetic ADH. We've made something to simulate the antidiuretic hormone. Oops, sorry. Just making sure I'm recording. So that's one thing. Then when you look down here, things that are really important, obviously when you administer it, it's given undiluted over 1 minute. Fluids must be restricted to make sure that you're monitoring them for water intoxication. So when you see stuff like that, understand what is water intoxication. Look that stuff up. The other thing you want to be looking at, so going over to your adverse effects, there it is. Desmopressin can cause symptoms of water intoxication, drowsiness, headache, listlessness, progressing to convulsions and coma. So what would be a priority nursing assessment after I give desmopressin? That would be the things that you want to make sure that you're looking at. So then it talks about other things that can happen. Your intranasal form can cause, think about it, anything nasal congestion, rhinitis, epistaxis. So it's all those things that it can cause. So it's just kind of important to understand that. It talks about, when it's contraindicated, you're looking at, obviously water intoxication. If a patient has diabetes insipidus that's not caused by the insufficient secretion of ADH, that would be if they have kidney disease, then you wouldn't want to give it to them. Drug. Look in here, it talks about, some of the NSAIDs is a big one. NSAIDs, people take that for pain. And it also talks about not taking it with lithium, alcohol, heparin, or epinephrine. So those are kind of big ones. And it talks about overdose being water intoxication. And how would you treat that? Water restriction and osmotic diuretic. So those are the big things that you want to make sure that you're looking at as you look at these things. But if you remember, what is the antidiuretic hormone? Why is it given? What is it for? Make sure that you understand that and pay close attention to that as you're going through the reading. Hold on just a second. Okay, so now you've got desmopressin down, and hopefully you won't forget it because you know what it is, and hopefully now by knowing what it is and remembering your dreadful pathophysiology, you'll remember how to remember it. So the next one I want you to go to is on page 748, your levothyroxine. So again, it's synthetic T4. What is that for? It's the drug of choice for replacement of patients who have low thyroid function. So it's basically an endogenous hormone that's replacing for someone who has low or doesn't have enough, T4. So when you're looking at this, make sure you pay attention to what it says. When given PO, 1 to 3 weeks may be required to have full therapeutic benefit. So if a patient says, I've been taking it for a week and I don't feel any better, then you need to tell them to give it a little bit more time. Or I've taken it a few days and I'm not feeling great. You got to give it more time. So other things too, it talks about serum TSH levels being regularly monitored when they're receiving it. High TSH level usually will indicate that the dose needs to be increased. So how do you know that the levothyroxine is working or needs to be adjusted? By measuring the TSH levels. Again, important. Okay, so why are we looking at TSH? Remember, your TSH is your thyroid stimulating hormone. It basically measures how much of this hormone is in your blood. Why is that important? Because TSH is what tells your is produced by the pituitary, and it basically tells your thyroid to make or release the other hormones. So by looking at that and saying that my TSH is high or my TSH is low, I'm going to be able to say, if my TSH level is high, my body is saying I need more of my thyroid T4, which is why you would increase your levothyroxine. So when we get into here, again, important thing is administering the medication at the same time every day, preferably in the morning, to decrease the potential for insomnia. I'm sure if you go up here and you look at or down here and look at adverse effects, they could be palpitations, dysrhythmia, anxiety, insomnia. So we take it in the morning to avoid insomnia, just like we take our diuretics in the morning so that we're not up peeing all night, right? Weight loss and heat intolerance. So looking at those things and thinking if it's mentioned twice or 3 times, it's important. Black box warning. Make sure use of the thyroid hormone in treatment of obesity or weight loss is contraindicated. So although this may lead to weight loss, it's not something we would use as a treatment for weight loss. Big thing here, a patient who is experiencing thyrotoxicosis is someone that we wouldn't want to give it to, or if they have any severe cardiac conditions, including a myocardial infarction. Think about it. What are some of the side effects? Palpitations, dysrhythmia. So you kind of want to look at those, and they go hand in hand. So take a look at that stuff and make sure you're looking at that. And then it looks at the drug. Make sure you take a look at things that you can't give it with. Herbs, soybean flour. These are kind of rare, weird things that if they stick out, you want to make sure that you're paying attention to them. Yeah, you all knew that was a Cisco update, right? I get those every day. I'm sure you all do too. So soybean flour is a big one. Cottonseed meal, walnuts. So that's kind of things that you want to be paying attention to because they're weird things, but they're stuff, if they're weird, you don't know who would use them. Make sure that you are teaching these things to your patients. So on to the next one. We are going to page 750. 750 PTU administered for patients with hyperthyroidism. It'll interfere with the synthesis of T3 and T4. So it's going to stop the T3 and T4. So again, make sure you're looking at your TSH levels to make sure that we know the appropriate dose. So remember, if we had a high TSH level, we knew we needed to give more of the levothyroxine. So an indication that your PTU would need to be increased would be a patient with a low TSH level. So that's one of the things that we're going to be looking at. Overtreatment can cause hypothyroidism. So remember, if we're giving it for hyper, what could be a complication? Hypo. Rash, leukopenia are frequent adverse effects. So leukopenia, what does that mean? Make sure you're looking at that. Another big thing with this is the agranulocytosis. And if you look over on the right-hand side, I think it talks about it again. It talks about the increased prothrombin time, increased serum levels of AST, ALT, and ALP. So liver, talks under interactions if it's given with anticoagulants, increased risk of bleeding under the interaction. So if you see bleeding, you see agranulocytosis, you see leukopenia, periodic blood counts for TSH levels. Again, like I said, if your TSH level is low, your PTU might need to be increased. Black box warning, severe liver injury and acute hepatic failure. Boom, bring your black box down to your lab test. AST, ALT, alk phos. So you kind of make that connection there. You're seeing it in multiple places, so you want to make sure you're paying attention to those types of things. Then the next one that we're looking at for this particular area is your hydrocortisone, which is on page 756. It talks about corticosteroids in general. What are we worried about with our corticosteroids? So when we look at these, remember, it's our SONE and OLONE when you're looking at these. Adverse effects for these: impaired wound healing, masking infection, adrenal atrophy. But that masking infection and impaired wound healing kind of go hand in hand. Hypokalemia, peptic ulcers. So these are things that you want to be paying attention to as you're looking at this. Heart failure, edema. So if you have a patient who's taking a corticosteroid, what would be important things that you want to make sure you're paying attention to? Those would be the things. Watching out, making sure they know those types of things. So that kind of goes hand in hand. So now I'm going over to 756 and I'm looking at hydrocortisone. So again, my hydrocortisone is a natural hormone, cortisol. So this will be the synthetic corticosteroid that's a drug of choice for adrenal insufficiency. So it's one we would give it. Make sure you pay attention to that kind of stuff. It's available in 6 different salts. Talks about that in here again. Make sure they take it exactly as prescribed. You see that with almost all of these hormone drugs in this chapter, is you want them to take them at the same time as prescribed. You've seen it over and over and over. So again, big thing, Cushing's syndrome. We just said that up top when we, when we give some of these things, you want to be looking at what are those conditions that can cause in this one. Signs of Cushing's can develop with high doses or prolonged use. So making sure you're paying attention to what does that look like? What would I see? If you're taking it for more than 2 weeks, anytime you take a steroid, you want to gradually decrease it and not just stop. It talks about your CNS effects. So that's a big one with these, is anything that has to do with the brain and heart. So headache, insomnia, anxiety, vertigo, confusion, depression. So brain, heart with corticosteroids. And then long-term use can cause peptic ulcer disease. Again, it talks on here about, some of the other things that happens, drug-drug interactions, lab tests. So the hydrocortisone can increase the glucose. Again, that goes hand in hand with your wound healing. So that would be something that would be important to make sure you're paying attention to. The cholesterol and the sodium. So these are other things that you would want to make sure you're monitoring while they're on this particular drug. It can also increase your uric acid or calcium. So what happens when those increase? They could end up with a predisposition for something like kidney stones. So that's why that's important to make sure that you pay attention to those. Diabetes, I'm not going to spend a ton of time on this. Make sure you know the difference. I know you just had this in Med-Surg, so hopefully it's free and right there in your brain. Make sure that you're looking at the generic. For all of these drugs, they're always going to be the generic. So make sure you know your rapid acting, aspart, lispro, glolazine, which is your Apidra, your short acting, your regular, your intermediate, your NPH, your long acting, your Detromir, and your glargine. So understanding that and knowing when you give these, generally, what would be your onset, what would be your peak, and what would be your duration. So if you remember which drugs are rapid, what's the short one, what's the intermediate, and what's the long, then you'll have an idea of when the onset is, what the peak is, and what the duration is. The big thing, too, is with your glargine is that there is no peak. So that's one of the big advantages of that. The other thing was that with that is it can last up to 24 hours so that they only have to take it once a day. Same with the Detromir. So think about, if you give the med to the patient, when are they at highest risk for having hypoglycemia? It's going to be when the drug peaks. So it's really important to make sure that you pay attention to that. Other things with this, obviously the major adverse effect is hypoglycemia. Knowing the signs of hypoglycemia, it talks about it on page 768. Signs of hypoglycemia include, make sure you're looking at that stuff. Making sure you're rotating, they're telling them to rotate the injection sites. I know you just went over that in 371, so make sure you revisit that. For your anti-diabetic drugs, I would make sure that you know what the particular type of drug class is. So obviously metformin is a biguanide. What does that mean? What does it do? What exactly is that going to do for the patient and the patient's body? So not, hey, it's going to drop their blood glucose, but I want you to look in here and tell me what exactly does the biguanide do? How is it going to work on the patient or for the patient? So make sure you understand that. So is it going to stimulate the release of insulin from the pancreas, or is it going to increase the patient's ability to utilize their insulin? So understanding the difference between these particular type 2 drugs is very, very important. Metformin's a huge one to know. It's a really commonly asked one on your boards. Big things with that, make sure you're paying close attention to the prototype box on 775. So adverse effects are pretty much GI. So, it's almost all GI, other than your headache, agitation, and fatigue. And obviously, anytime, you worry about them, what else can happen. So the big thing with the metformin too is that it's less likely to cause hypoglycemia than your sulfonylureas. So that's one of the big advantages to that drug. Contraindications in patients with impaired renal function, because it can lead to toxicity. So, renal, heart failure, liver failure, lactic acidosis. So like pretty much any potential that it's causing issue with the patient's organ systems. If they have any impairment of their organ systems, you pretty much know not to give it. The drug, or to use it cautiously, or make sure you tell the provider. Big one with this is use with IV radiographic contrast can cause lactic acidosis and acute renal failure. Make sure you understand that. Make sure you're looking at that. It's a very, very important aspect of administering this medication. So again, make sure you're looking at that. All right, let's get to some questions. And I didn't even switch the slide. I'm sorry. You're probably like, what is she talking about? So here, the other thing here is just know what you would teach them if they have combination drugs, but we're not expecting you to know them. Make sure you look at the stuff that's on here and look at your study guide. It'll give you a very good indication of what you need to know. So this question, the answer is 3. Desmopressin, again, is the same as ADH, which is your antidiuretic hormone, and acts on the collecting ducts in the kidney to increase water reabsorption. So that's a really important thing for this. It promotes water retention, and it is a potent vasoconstrictor, not a vasodilator. It can cause blood pressure to rise, not fall. It does not suppress hormone secretion from the posterior pituitary glands. This one is 4. Insomnia, we talked about that, is an adverse effect of levothyroxine. Altered sleep patterns must be assessed. That's why we talked about giving it in the morning. Daily temperatures are not necessary when taking this medication. The appetite tends to increase, not decrease, with patients receiving this medication. And serum blood levels are not required on a weekly basis for patients receiving levothyroxine. This one, the answer is 3. So clients treated with radioactive iodine therapy often end up with hypothyroidism and require replacement therapy. Treatment with radioactive iodine usually results in a permanent euthyroid, so thyroid isn't functioning state. This therapy is contraindicated in pregnant patients. Physical distancing is necessary for others to prevent exposure to the radiation. This one, the answer is 1. Foods high in iodine, such as soy sauce, can affect the effectiveness of medication therapy in patients with hyperthyroidism. Milk products should be included in the diet for the client with hyperthyroidism because they are high in protein and calcium. High-calorie foods are important for these patients in order to meet metabolic demands, and there is no reason to restrict caffeine. Okay, so this one is 1, hypernatremia and hyperglycemia. Hypernatremia and hyperglycemia are seen due to the aldosterone effects causing sodium and fluid retention. Elevations of blood glucose due to promotion of glucogenesis. Hypernatremia would be seen, but hypokalemia would be seen, not hyperkalemia. Hypercalcemia and hypokalemia would be seen in this therapy. Hypoglycemia and hyponatremia would not be seen with hydrocortisone therapy. So the answer is 1, hypernatremia and hyperglycemia. Let's see. All right, next one here is 3, hypertension. Hypertension, not hypotension, would be expected related to the increased production of angiotensin II. Hypothermia would not be seen. Temperature regulation is not related to glucocorticoids therapy. Weight loss would not be seen. Weight gain is more likely with this therapy. This one is 1. The medication must be taken at the same time of the day to maintain serum levels. Remember, we said take these at the same time. Almost all of your drugs that are used for replacement of your hormones are going to be taken at the same time, whether it's thyroid or whether it's the glucocorticoids. Any of them, they're always going to pretty much be want you to take them at the same time. This one is 3, lower the activity of the thyroid hormone. That was kind of self-explanatory. This one is 1, 2, and 4. When given orally, it may take up to 3 weeks. Remember, we said that they have to be patient. It may take up to 3 weeks for the full effect of the drug to be realized. The serum TSH will be drawn frequently as the patient begins this therapy and to monitor its effectiveness as the therapy continues. Dietary fiber may bind to and decrease the absorption of this drug. Calcium and iron supplements should be taken at least 4 hours after levothyroxine to prevent interference with drug absorption. The medication should be taken at the same time every day. Again, same time every day, not at variable meal times. It should be taken in the morning to decrease the chance of insomnia. This one is 1, 2, 3, and 4. So the action of the drug may be delayed from several days to as long as 6 to 12 weeks. The drug may cause gastric upset, which is decreased by if the drug is taken with food. So PTU with food. This is a pregnancy class D drug. Rash is one of the most frequent adverse effects, and the drug should not be taken while breastfeeding. This one is 1 and 2. The patient on long-term corticosteroid therapy is at risk for osteoporosis and should avoid carbonated beverages. Regular weight-bearing exercises help to strengthen the bones. The patient should have a sufficient calcium intake either by foods or from supplements. There is no specific reason to schedule colon studies or to avoid caffeine intake. This one is 2. So the onset of action for insulin Lispro, Humalog, is 10 to 15 minutes, so it must be given 5 to 10 minutes before the patient eats. So what would be a priority nursing intervention? Make sure the food's there before you give it. Recently, I worked in a hospital where they had a new food service, and their insulins were all scheduled at 7 o'clock in the morning, but the food wasn't coming until like 8:30 or 9. Well, what's going to happen? You're going to have a bunch of hypoglycemic patients by the time their food comes. So they ended up having to get the hospital to change the order. So instead of being 7 a.m., it was to give it within 5 minutes of the meal. And then the company that was delivering the food, or the food attendants nutritional attendants, would have to actually notify the nurse when they got to the floor and leave it outside the room so that the nurse could get the insulin and bring the tray in at the same time to avoid hypoglycemia. And when is a patient most at risk for hypoglycemia? When the insulin peaks. So it would have peaked if they didn't get them their meals. The answer to this one is 1. Lantus insulin is usually prescribed in a once-a-day dosing, so an order for BID dosing should be validated with the physician. So again, it's usually once a day. It lasts for 24 hours. So the answer to this one is 2. Whenever a patient who has type 1 diabetes is found unresponsive, the nurse should always focus and treat for hypoglycemia. Your institutions will have a protocol that tells you what to do. So it's very, very important. Assessment of the ABCs should precede calling a code. There is no information that the client was not breathing. So it's an emergency situation and the nurse must act before calling the physician, and vital signs should be taken after the patient is treated for hypoglycemia. So if you have a patient with type 1 diabetes who is unresponsive, again, it doesn't say they're not breathing, you always assume hypoglycemia and treat for that first. How would you know that they were at increased risk? When did they get the insulin and when does that insulin peak? I've said that a million times. The answer to this one is 1. Unopened vials can be stored at room temperature but should be stored away from direct sunlight or direct heat. There is no need to discard the vials. Writing the date of opening on the vial is good practice but does not address the need to refrigerate additional vials. There's no indication that this is too much insulin to have on hand. Answer to this one is 3. Insulin must be injected because it is destroyed if by the stomach acid if it's taken orally. It cannot be given orally. The answer to this one is 1 and 4. Metformin decreases sugar production in the liver and reduces insulin resistance. It does not inhibit the absorption of carbohydrates or increase energy use. So again, it decreases sugar production, which is the glucogenesis of the liver, and reduces insulin resistance. Answer to this one is 2. Alcohol can potentiate hypoglycemic effects in the patient. It can cause pancreatic disease, but the client's pancreas is not producing any insulin currently. Alcohol can cause liver disease, but the more immediate concern is the hypoglycemia. Alcohol can potentiate hypoglycemic, not hyperglycemic effects in the blood. Answer to this one is 1. Insulin causes potassium to move into the cell and may cause hypokalemia. So because the insulin causes potassium to move into the cell, hypokalemia can occur. There is no need to monitor the serum amylase level. There's no need to monitor the AST, and there's no need to monitor the sodium. This one is 3. Regular insulin is the only insulin that can be given intravenously. Answer to this one is 1. Metformin is the only drug that falls within the classification of the biguanides. And then finally, the answer to this one is 1. Garlic can potentiate the hypoglycemic effects of insulin. So you need to be very careful and make sure you teach your patients, especially those of us who love our garlic. And if we had to take insulin, we would need to make sure that we didn't take too much and that we were aware that it could potentiate or make the effects of it stronger. So anyway, I will upload this as soon as I get a chance, but I wanted to make sure you guys had it. And so did Professor Lombard. Unfortunately, hopefully her computer's getting fixed, but she did try to record for you guys, and it was important to her that it got to you. So good luck on your exam. Reach out if anyone has questions. And have a fantastic Monday night.